Okay, well, thank you to the presenters. 3 really interesting presentations. Very much enjoyed those. We don't have any questions that I can see yet in the Q&A. Happy to receive any of those. I have a number of questions for Julian and Tim, who are both around to be able to receive some questions. I might just ask first, though, if there's anyone in the room that has any questions that they'd like to ask first. And if not, I'm going to get underway with a question focused for Julian firstly. And Julian, you had some very interesting discussions about the relevance of pharmacogenomics. And that was presenting some data from studies where they had characterized what that effect on drug exposure was. You also mentioned that there were a number of drugs whereby it was still uncertain because those equivalent studies hadn't been done. And so my question for you relates to how would you design a pharmacogenomic pharmacokinetic study to be able to characterize what the effect of pharmacogenomic variability is, such that one could generate one of those dosing nomograms, which, for instance, you're using in your prospective studies at your hospital, and that others apply to other drugs?
Yeah, thanks, Jason. That's a loaded question. The problem with antifungal drugs, especially in the setting of prophylaxis and how effective it is, and actually even more so in treatment, is you need huge patient numbers to like define the effectiveness, because there's one thing to talk about. It's very easy to look at a straight level of a drug, but I think this is the challenge right now with isavuconazole, that we don't know. We have a range that the original phase 3 clinical trials presented and said all of our patients were in this range, but they don't really correlate per se with infection rates. There's multi-compartments, as you know very well, and so perhaps the serum level of a drug is not the most important thing. Maybe for CNS infections, the CSF levels might be relevant. And so I think the first thing to do is probably to work out the PK/PD of a drug and its effectiveness. Potentially prodrugs and different active metabolites may play a role in that in different compartments. And then when you have that, you could then work out, looking at like assessing patients' genomics as to whether there's differences. Like, for example, that Korean study worked out that the actual absorption was affected by the UGT genotype. And so I think you have to think about all potential areas in which the drug is relevant in the system, to have a lot of patients. So I think ideally, and we're probably going this way, that big phase 3 clinical trials of new drugs should be testing pharmacogenomics of relevant enzymes, at least, especially for drugs known to be metabolized through enzymatic mechanisms, to look for correlations. But I think the really tricky part is then looking at the efficacy of that drug based on those polymorphisms, and that's the hard part. So it's definitely not an easy task.
So just to go a little bit further into that, we have a question from Andrew Burke on this topic about sample size. What your estimates would be about, let's say with the voriconazole literature, what kind of sample sizes do they use to initially establish that there may be an important pharmacogenomic relationship, and then to describe that it was sufficiently important that you should be tailoring dosing based on the pharmacogenomic in the individual patient?
Yeah. So that's really interesting. Most studies only have a couple of hundred patients in them, and depending on the ethnicity of where these studies are, there's different proportions of whether they're a poor metabolizer, ultra metabolizer, and so forth. So to get enough patients to see the thing with voriconazole is it's very easy to correlate a number, like a level of drug, voriconazole, with a metabolizer. If you're a poor metabolizer, you can literally look at levels. Most of those studies only look at sort of 50 to 100 patients, and sometimes in the poor metabolizer group, there might only be 5 to 10 patients. Now, the largest studies are about 200 patients, and they are what is describing the use in clinical practice. But those studies are really using a theoretical efficacy of the pharmacokinetic, the number, essentially, the drug level, time to achieve therapeutic levels, and then they infer the clinical efficacy of using that. And so right now, to my knowledge, in the anti-infective space, I know it's very different for say, codeine and morphine, because you could just give it to 50 people and get a pain scale and see the effectiveness of it. But it's much more difficult with an anti-infective to do that. So right now, I don't think there's any anti-infectives that use pharmacogenomics that actually have an efficacy as a primary outpoint, because you would need huge numbers to assess that. I think I answered the question. Is that what you're after?
I think that's a really good comment, that it's really a quality endpoint that people are looking at, and that quality endpoint is instructive of what's been observed in other studies. So, for example,
correct,
for voriconazole, there has been a TDM-focused study which has defined the importance of maintaining the concentration in the therapeutic range for improved outcomes. So that
exactly.
makes a lot of sense. Thank you. Next question relates to the importance of turnaround time. I know that this is a big challenge depending on which centre that one is in. And so, at your site, you're very lucky to have facilities available to you, but even then the turnaround time may be 7 days. And then for other sites, perhaps which don't have that similar facility available on campus or in the city, it may be a longer turnaround time. I wonder if you could just give us some comments about at what stage is it, well, it doesn't matter about doing genomics because the turnaround time is just too long. Just some broad principles about that.
Definitely. And that's the main challenge of thinking about how you want to use it and what you can use pharmacogenomics for. I didn't mention in my talk, but one really nice study that was presented at a tandem meeting, which is the allo transplant meeting. I discussed all these issues with allo transplantation, and a pediatric allo site in, I think it was Miami, or another big US site, actually was doing a full panel on all patients leading up to their transplant, and then there were pediatric transplants. As was mentioned in Eve's talk, that information then is relevant for the rest of their life. And then throughout their entire transplant, they could adjust every drug. So, they didn't give oxycodone if they were 2D6 poor metabolizers, if voriconazole was prescribed. So that's sort of like one strategy that you could use. And I feel like that's where pharmacogenomics is going. I think the tests are becoming cheaper, and a lot of patients will send away and have that on their record, just like an allergy, and you will be able to use that information. But in saying that, you have a new AML present. They've been neutropenic for 2 weeks before their diagnosis. They're actually diagnosed with invasive aspergillus fungal infection on presentation, and they don't just happen to have a CYP2C19 genotype in their history. You really want to be knowing that result as quickly as possible to get the most effective levels as possible. So it's definitely debatable what model you want to use. I personally really like the model of doing a full panel early and then having that information. It's a cheaper way of doing it, but you have to sort of have a patient in a circumstance where that's possible. So I feel like there's always going to be a role for rapid testing. It's just maybe like a cost benefit of trying to get the people that have time to sort of, get the panel done and have that put into their history. And those that don't, you might have to pay more, but it'll become less frequent in time as more and more people are getting these panels done, because it doesn't change unless you have a liver transplant.
That's great. What about the difference between matrices? You mentioned that sometimes saliva is used, sometimes blood is used. How is that done? Is it all defined on blood first and then a saliva test is developed and validated against that blood standard?
No, not necessarily, because some commercial labs will be validated to use a saliva sample. And I'm not sure about Australia, but I know there are FDA registered sites and facilities, and they have a validated method of DNA extraction from saliva. And once you have any small amount of DNA, you can then amplify that and then use that to put into a PCR to test. The tricky parts, like I mentioned, is, and so essentially whether it's a saliva or blood, it's site dependent what they have validated for their sample. I don't know, technically places should be able to do a swab because I know some genetic testing is done with swabs. I personally don't know of any site that does pharmacogenomic testing using swabs, but I definitely could be corrected that they're out there. But the real challenge though is coming with most sites are validated with blood, and there's a lot of patients, allo transplants, especially in antifungals, are one of the highest risk groups. And right now, there's just no test that's validated because there's a worry about donor contamination, donor DNA contamination, even in a saliva or a swab. So that's definitely going to be, I wouldn't say breakthrough, but definitely when someone could figure that out, it's going to be excellent. But you just have to think about it. You have to think about what sample to use the appropriate sample. That the liver transplant group, and this is actually more evidence of if you already know a patient's coming in, if you already know that they're getting a liver transplant, it only costs, say, $100 for a long-term, like 2-week turnaround, but full panel, then that might be a really useful thing to give all your liver transplant patients because of the number of those patients that will require a drug at a later stage that pharmacogenomics can be implemented for their therapy. So it's all about planning, I think.
Right. I've got one more question, assuming that no one else does have one here. When you're reviewing a paper which has a pharmacogenomics component to it, let's say that it's a clinical study which measures some form of outcome. It could be a qualitative one, it could be a clinical outcome. What would be the main things that you would look for to look at the quality of the use of pharmacogenomics and that it has been optimized to ensure that the likelihood of it delivering a benefit can be measured?
Yeah, I think that's really important because it's a buzz area right now, or using genomics can be very enticing. And I think it all comes down to a clinical benefit. Even if it's a theoretical clinical benefit, I think that needs to be really clearly stated in a paper. I know that the Patel paper that I spoke about earlier in the voriconazole, they did the testing. Yes, they used appropriate validated methods for phenotyping. So that's something you have to think about. Are they validated? Are the sort of SNP segments well studied and thought out? Once those phenotypes were being used in the right category, what was the actual outcome that those phenotypes were being associated with? Voriconazole is easy. They're associated with a trough drug level. Okay, great. But there was some of the sort of discussion and I think results about a cost saving. But if you really read into it, they sort of infer that if you're subtherapeutic, then there's a high chance of a fungal infection at a rate of 5%. And then if there was 5% of patients getting a fungal infection, then it would cost this amount. And I think that's probably pushing the envelope a little bit too far in the benefits that papers are saying that are coming out, if that makes sense. I think that you have to really think about what is the clinical relevance of doing this test. Could you just do a drug level 2 days after starting it and then get the exact same result as doing a CYP2C19 test and then coming up with a potentially more relevant dose? Or can you just use TDM? Is is it actually a benefit, or is it just sort of cool to do it? So I feel like validated phenotypes, the right patient population, and the actual outcomes that are being measured are probably most important. And I have picked up a few papers that I've reviewed where they have used an allogeneic transplant and they've used a blood sample, and it's gotten all the way to the point of being reviewed until I sort of say, hey, you're testing the donor's liver enzyme on that one, so you'll have to exclude those patients. So there's a few little things you have to look for, but I think the at the end of the day, the primary outcome is that's being assessed is relevant.
Thanks. And there's one more question that's just come through, but I'm about to invite Tim up, but you're going to get this one while Tim comes up here, if that's
All right.
okay.
Of course.
About ethical issues that may need to be considered when ordering a genetic test. Is there anything that we need to consider, even if we're using it just to predict PK rather than diagnose a disease, which may have implications for family members or life insurance? Again, that's from Andrew Burke.
Yeah, that's actually a really interesting point, and it's something that has maybe come up once a long time ago when we were looking at genetic testing of allo patients, and at the moment, I think ethically, if the scope of what genetic tests you're doing is to say the phenotype of an enzyme, and you're not sort of storing the sample or testing a wide panel to look at other things, then I don't think it sort of crosses any ethical concerns. If you're using the wrong sample and you're testing the blood of a donor, then yes, you shouldn't be doing that, because that's the patient can't consent to the donor's genotypes being tested, so that's fair enough. But I think what is a little bit more concerning is where there are long-term diseases linked to having deficiencies of enzymes, rather than just the drug that you're looking for. So as more information is put out there with the consequences of phenotypes, other than just how fast they can metabolize a drug, then yeah, there might be some ethical concerns with that. But at the moment, the only time that those ethical things have come up is the lack of consent of doing allo patients or liver transplant patients, needing the consent of the donor to get their genotype and that kind of thing. But it's definitely something to keep in mind with all genetic studies moving forward, for sure.
That's great. We've made you earn your keep. Now we're going to make Tim earn his. So Tim,
Right.
Are there any ethical issues with doing genomics on bacteria?
Yeah, so I suppose our view in pathology is that we own the bugs don't own us.
Yeah.
So yeah, we don't really have that issue in terms of, but certainly if we start looking at things like metagenomics, where we are amplifying up host DNA, it's certainly something that we need to be mindful of. The way that we would manage something like that is that we basically filter out the human genomic reads and bin them, so it would never ever actually get analyzed. But certainly, it's come up many times before in terms of how do we implement these methodologies. I mean, with my CF cap on, and going back to the last question, we've been genotyping CF patients for over 25 years now. We think nothing of doing that, and we now have potentiators and modulators that are specifically designed for certain CFTR genotypes, and the patients benefit from it, and it's part of their treatment.
Yeah.
So I think we're actually using this information to better the patient, and provided it's, everything we do is bound by privacy as healthcare practitioners, and I think as long as that's maintained, from my point of view, I think it's a good thing for the patients.
Yep. So my next question to you relates to proteomics versus genomics, and measuring the presence of a gene doesn't necessarily mean it's being expressed. Are you able to comment on the need for validating the relevance of genomics from a proteomic perspective, that it is going to be expressed and is something that's relevant as opposed to something that's present and may not actually be clinically consequential? How does that get taken into account?
Yeah, so, that's a really good question, Jason. And I guess that's, the RNA-seq work that I presented is, it's not proteomics, but it's pre-proteomics, if you like. So just because something's there doesn't mean it's functional or it's being used. Now, this is something that certainly from a traditional perspective, looking at, say, antimicrobial resistance, we do have very good data that, generally speaking, if something's there, and remember, we always have a resistance phenotype, so we can see that it's doing that. Having said that, we do frequently have instances where the phenotype mismatches with genotype. A lot of the time when we see that, it's often that an organism's dropped the plasmid because it doesn't have the selective pressure that it was under when it was in the patient and under drug sort of treatment. But similarly, and we had an example of this recently with a vancomycin-resistant enterococcus. So the genes are there, the phenotype is there, but it's subdued. So this is where, presumably there's mutation. So it's not a functional mutation, but it's deleterious to the function of that particular gene. And so I think, moving forward, there is probably going to be a place for proteomics / transcriptomics. It's obviously very expensive at the moment. So, there's a cost factor here, but certainly, we have a project that's funded at the moment where we're potentially going to look at, say, a new model of biofilm-based sort of antimicrobial resistance susceptibility testing. And this is where we could use RNA-seq type technology to really see what's going on in this particular model compared to our normal kind of broth microdilution methodology, and look to see exactly what we did in the mouse model to see whether, using this sort of technology allows us to understand what's going on with regards to the organism and treatments that may be applied to the organism.
Great. Final question for you is similar to one that I gave Julian, but from a pathogen genomics perspective. When you're looking at a paper or a protocol which is proposing to use pathogen genomics and applying that in a clinical context, from a laboratory and a reporting perspective, sampling perspective, what are the main issues that you're looking for to make sure that the results are going to be valid and therefore meaningful?
Yeah, so look, for us, as we were talking about before, like in terms of pathology, validation is the absolute key. So we want to be able to ensure that we can actually effectively validate the test and consequently introduce the test into our routine diagnostics. We're probably not going to be looking at something that, one, doesn't allow us to have a decent turnaround time. That's because we need to deliver. It's got to be, I suppose it's got to be something that we could see that, multiple people could be trained on. Something that's ultra complex is not going to work in the broader sense. Sure, we can have specialty tests, but effectively we need something that can be applied sort of quite broadly. I think that's probably one of the other really key components. But basically anything we can validate, we can effectively turn into a test. The real key for us is funding it, but that's the bottom line. We've been very, very lucky to have an injection of funding to both human and microbial genomics very recently in Pathology Queensland, and up until then it's made things very, very difficult. So it's a real godsend for us to be able to be granted that. But I think the reason that's happened is because clearly these things is going to become more and more common, and we want to do more and more of this, and we need to have the logistics and the funding behind us to actually be able to deliver on it and be able to actually undertake these complex validations to see if we can offer these tests to patients.
Fantastic. So for those of you out there looking at doing some research onto this, please include a health economic analysis so that we can work out exactly what the cost benefit of this is. I've got a question here from Sarah Bell. I know we've just run over time, everyone, and you might have to drop off if you need to. Where is the development of genomics up to in identifying chains of transmission for diseases where there may be criminal implications, such as HIV? I don't know if we've got anyone that... does anyone have a go at answering that one?
Oh, I mean...
Tim wants to.
So... I haven't got anything involved, sort of any experience involving criminal implications, but there has been a lot of work that's been done on kind of looking at networks of transmission. And that's something I have had quite a bit to do in the context of cystic fibrosis. And certainly it's been done with regards to other sort of STIs that's most typically being done in, and also funnily enough, animal-borne diseases like bird flu.
Yep.
And so there is some quite sophisticated sort of algorithms you can use to test this and combine genomics in with that. How that you deal with that in terms of the legal kind of parameters, I'm not qualified at all to comment on, but certainly, you know, this has been done in a research kind of mindset previously.
All right. Well, Julian, do you have any comments on that, or it's a tough one?
No, I mean, as far as I work with, they're just taking a PCR and an amplified piece of DNA. So I'm not doing full transcription, or I'm not pretending to know how to do it at all. But very, very briefly, just thinking back to the last question about ethics, I think it will be interesting moving forward, and I think it will be very important, especially here in the US, and that sort of does happen in Australia with health insurance, that at the moment, I don't know of any health insurance disqualifying people because of being a poor metabolizer and therefore not being able to use a drug. But it's probably something to be aware of, because the FDA really have only in the last couple of years been implementing pharmacogenomics into labels for drugs, and health insurance companies are unfortunately not far behind that. And so I think it will be very important to stop that from happening, essentially. So it's just something for everyone to sort of be aware of, that you know could happen, and to definitely to be aware of it not happening and do what you can to stop it.
Thanks so much, Julian. Thanks so much, Tim, and thanks so much, Eve, for your presentation as well. I hope you all enjoyed those. I thought they were fantastic, very interesting, and really give us a glimpse into what's happening at some sites now, what some of the cutting edge research is, and maybe what's coming in clinical practice to many, many campuses around the country and internationally very soon. So thank you for those presentations. I'd like to remind everyone about our next upcoming seminar, which is going to focus on obese patients. This is going to be on the 29th of August, which in Australian Eastern Standard Time is from 6 p.m. to 7:30 p.m. If you're around in Brisbane and want to come and join us, please do. Just click on use the QR code there to register, or alternatively just go to the CRE Respond website. I'd also like to just let people know that there is a workshop which is also being run in Brisbane on the 29th and 30th of August. This is being run by the Jamison Trauma Institute through the Queensland University of Technology, who are partners with University of Queensland in much of the work which is being run through Jamison Trauma Institute. This workshop focuses on trauma, surgery and burns infection management. It's very wide-ranging in what the content is, got some fantastic presenters. It's a very topical area, and so for those of you that may be interested in attending that workshop, we would certainly encourage you to do so. In November, there is a non-tuberculous mycobacterial symposium. This has been led by Dr. Andrew Burke, who asked a couple of fantastic questions earlier today, and many of you will know him from chairing seminars from CRE Respond as well. We encourage those of you that have a clinical or research interest in this area to register for this event as well. Again, the QR code is present there. It runs for 2 days from the 16th to 17th of November. Again, it's in Brisbane. This is at the main medical school in Hurston. And finally, for those of you that are in genomics, the Hurston Infectious Diseases Institute are planning on running a pre-Heidi forum workshop focused on pathogen genomics, which will be run during Antibiotic Awareness Week. So for those of you that are interested in that, please feel free to reach out to us here at CRE Respond or me personally, and I can keep you updated about that. That program is being developed at present, but that's something which of course will be of interest to those of you here. other research education opportunities, please visit the CRE Respond website, whereby you can register for events and therefore be on our mailing list to see what kind of other education events are about. All of our different seminars are uploaded to our YouTube channel, so we've got an amazing library of resources there that you can always go and access at your leisure. We would invite you to follow us on Twitter, and we're at CRE_respond, and we're also on LinkedIn as well. Thanks very much, everyone, for joining us. A really good session. Really grateful to the speakers for their presentations, and I look forward to seeing you next time. Thanks.